So let me begin by telling you a little bit about who I am and what we're going to do today. Today we're going to be talking about evaluation. I know you know that because you've read your notebooks from front to back and have looked at all the materials. I'll talk a little bit about the readings in a moment, but I just wanted to say a little bit about who I am and my experience in talking about evaluation. So my name is Pat Ocampo, and my training is in social epidemiology, or really in epidemiology, but my practice is in social epidemiology. A lot of the work that I do concerns the social determinants of health. I hope you all have heard that term. Is this too loud? No? Okay, all right. I have been doing evaluations for close to 30 years. And all kinds of evaluations, clinic-based evaluations, community-based evaluations, small randomized trials, large randomized trials. So I think evaluation is very important for a variety of reasons. I think, and this is my own bias, and I've actually published it in a book, which I'll show you the cover in a moment. I think that as epidemiologists, so how many people here consider themselves epidemiologists? Yeah, okay. So as epidemiologists, we do a great job of describing problems, but we don't do a great job of identifying solutions. In that sense, I think we don't do a great job of doing enough evaluations and the right kind of evaluations. So that's a bit of my mission in life, is to talk a little bit about the need for us to do more evaluations. A couple years ago, I published this book called Rethinking Social Epidemiology Toward a Science of Change, really urging epidemiologists not to give up describing problems, but to really begin to acquire the skills and focus more on identifying solutions, because we have a lot of work to do in that area if we're to address the growing inequalities, et cetera. So I'm not telling you to buy this book, but I'm also just giving you an idea that my 30 years of experience has kind of gone into arguing for evaluations, but not necessarily straightforward evaluations. Each program is unique, and each program is often complicated, and so we need to tailor our methods that we apply to evaluation. So in this book, for example, I talk about some of the newer emerging methods of evaluation as well. And we're going to talk about that this morning. So the format for the day is going to be that in the morning now, I'm going to start by just giving you a flavor of what some of the emerging issues are in evaluation. Evaluation is an evolving field, so I just thought I would give you a flavor of that. And then we're going to begin the exercise portion of the day. So we have 3 exercises to do. I'll tell you a little bit more detail in a little bit, but you'll be working in groups and working on 3 exercises, evaluation exercises. And there's going to be a lot less lecture today and a lot more of you working together. I'm going to be like your consultant, so there's going to be times for you to come ask me questions. Certainly all the faculty are available to answer questions as well during the time that you're doing your assignments. Let's see if anyone has any questions. It's informal, so please raise your hand anytime that you have a question. And let's see right now if you have any questions before we begin. Okay. So, all right, so to begin with, we're going to talk about some emerging issues in the field of evaluation, in particular some evolving concepts. So I'm sure everybody knows what a word cloud is. A word cloud is a depiction of words that are important to a particular topic. The larger the words, the more important that word is. And so this is a word cloud for evaluation. You probably recognize some of the words as being important. Outcome, for example, causality, formative. So we're not going to go through each word this morning. I want to get a sense of what your experience has been. So I've told you a little bit about me. Maybe you can tell me how many people have been involved in no evaluations whatsoever? Okay. How about 1 to 3 evaluations? More than 3? Okay, great, good. Even if you haven't been involved in evaluation, that's okay. Your team members are. I'm hoping that you did the background readings. So we gave the background readings for a reason, so that you have at least that much basic knowledge about evaluation. Let's see. I want to talk about a couple of things. One is theory. Theory and key ingredients. Can anyone tell me why theory is important for evaluation? Is it too early in the morning? Theory of change? Theory of change? Yes, thank you.
Conceptualizing what you want to do and what you want to achieve.
So,
You have to have a vision to come up with an intervention or something, but what exactly is the goal? Just to determine that and how we want to get there, we need different visions.
okay.
We come up with a theory at the beginning and we work with it as we go along.
So a theory is important for helping us achieve our vision was the answer, yes. I'd like to add to that. A theory of change tells you what it is about an evaluation that is going to lead to the outcome. I'm starting with this because this is a really important point. Oftentimes when we describe when we describe programs, we describe the components or the activities. Okay, it's a health education program. That's actually not the theory. Or, peers are going to be involved in the evaluation. In the program. That's not really a theory. You have to have a theory of change. All programs are based on some kind of theory of change, whether it's implicit or explicit. And it's important to get at that theory of change. Why? Because it's really the theory of change that you want to, if it's successful, it's the theory that you want to replicate and implement when you scale up the evaluation. Not necessarily 3 case managers and 2 health educators. It's what they do to achieve your outcome. Okay, so theory of change, critical ingredients, that's really important, and we'll talk more about that later. Let's see. So maybe I'm going to share with you some of the other slides, and we'll come back to this. So ask any question you want about any one of these words, okay? And we have until about 9:30 this morning to kind of go over what's here or whatever's missing. And then we're going to get very specific about the exercises after that. So I want to talk a little bit about the idea of complexity. And this is important for a number of reasons. This is the Cunningham framework. And it's this idea that we have different kinds of problems that we face. So I'm sure everyone's going to understand a simple problem to solve. I'll give you an example of potentially a simple problem to solve with a simple intervention, maybe managing blood pressure. We know that that's not easy to do, but it's fairly straightforward. You can measure it fairly accurately and easily in a clinic setting. Then you can come up with any number of interventions to administer, and often you can control it. It's fairly straightforward. Complicated, complex, and then chaotic. We can actually evaluate simple, complicated, complex. It is hard to evaluate chaotic because it's unpredictable. You actually don't know whether A is going to predict B, etc. Let me give you some examples. So simple might be like baking a cake. You have a cake, your favorite cake recipe. You have a recipe for, your favorite cake, you have a recipe for it. You may not necessarily need a whole lot of expertise as long as you follow that recipe. A good recipe produces a great cake, and you can probably produce that cake each and every time as long as you closely adhered to the recipe. Complicated is more like sending a rocket to the moon. You have many protocols in place about many different aspects of sending that rocket to the moon. You also learn from experience, like you do with baking a cake, right? With baking a cake, your 10th cake is better than your first cake. Your 10th rocket is also better than your first rocket. And you do need a high level of expertise, though, to design those protocols and to implement them. You need special kinds of engineers, physics, etc. The key elements of each rocket must be identical in order to succeed. That doesn't mean you can't improve. You can certainly improve. But this is sort of a complicated protocol to implement, a complicated activity to do. And success depends on how good your protocols are, your blueprints. But again, you can learn and you can replicate it. Something that is complex, however, is more like raising a child. Rigid protocols aren't going to work. Actually, raising one child may not necessarily mean success for a second or a third child. Children are different. They interact with their environments, and their interaction with their environments may lead to different results, right? Twin studies tell us that. Expertise helps, but it's all, you have to balance it with other things. Some of it's experience, and some of it is responsiveness with the child. So you get the idea that you can't have protocols with something that's complex. You can't necessarily just train yourself to be the best parent in the world, and then when you have your child, it's going to all work out. It's a complex, not straightforward relationship between having the child and then achieving certain outcomes. So hopefully that's somewhat clear. Well, what are the implications of these three ways of these three problems? One is, in terms of evaluation, you know, if you want to bake a great cake, get good recipes, closely adhere to them, minimize modifications, and then you'll have success every time. For complicated, formulate good protocols, stick with the protocols that lead to success, adhere closely to the protocols, and then your success will increase with experience. For raising a child, however, protocols really can't be developed. You can have guidelines, but then you have to tailor those guidelines to the child. So there are guidelines about the kinds of parenting, for example, that may be better versus not. Nurturing environments are better, et cetera. And successes should be noted and monitored, refined. You have to document your process, and it's a bit iterative. And success at one stage won't guarantee success at another developmental stage, okay? So these are different ways of describing problems, and they also require different models for evaluation. So when you're thinking about your, your exercises today, or the evaluations that you're working on, actually, can I get so who here is going to be working on, or is working on an evaluation, or will be working on an evaluation in the near future? Great. Okay, so who here is going to deal with the simple problem with their evaluation? Nobody. Okay. Who's going to be dealing with a complicated problem? Wow. Who's dealing with complex? Okay. Can I get a sense of what some of those issues are? Do you mind telling me?
Sure. So I work for the state of Ohio in Medicaid. I'm the head of the analytical unit. I'm not an epidemiologist.
Okay.
Oh, I'm sorry. We've been very specific in targeting people who have been both high cost as well as having some kind of a condition that that could be modifiable, that they could have an impact on actually producing better results. We've been very prescriptive in what they need to do in terms of they need to assess individuals within 30 days, they have to design treatment protocols, they have to have face-to-face contact at least once a month. And this is very different than anything we've done in the past. And so we've been doing this program with the managed care plans, and we've told them that they need to have at least 1% of their members, of their most costly 5%, in this high-risk care management program. Now, on top of that, in Medicaid, we've also implemented many other programs along the way, ranging from implementing health homes that are really designed, they're mental health, basically, health homes. That's where we started. We've also expanded Medicaid. And so we have different populations coming in. We have changed the composition of the managed care population because we've actually included more and more people into the managed care arena. Among those are children with special needs. They never used to be included. And so there's a lot of things that have been going on top of just this high-risk care management program. And in the meantime, and we're trying to do an evaluation of has this been successful and actually been able to lower costs and improve health outcomes for the population that's been in high-risk care management. Wow. And I think it's very complex.
So your outcomes are reduced costs and improved health with all these different strategies, some of them new, some of them addressing new populations.
That's right. And we for improvement in health outcomes, we've kept it pretty simple in just looking at reducing admission rates and readmission rates as well as ED visits. Okay. And the evaluation actually that we are doing, the contractor is doing a propensity score matching design evaluation project. So, interesting choice. Okay, so who else has a program that they're going to evaluate or wants to describe it on this side of the room? I saw hands go up. Thank you.
I am involved currently in 3 different kinds of evaluations. One is literally starting. I have just put together a logic model for it, just conceptualizing like how we want to bring the whole community together, any resources that are available. Because I'm sorry.
Which community?
I'm from Louisville Metro Health Department. It's a county health department. It's independent from the state of Kentucky. I'm from the state of Kentucky. So
you said you wanted to bring the community together. Which community did you want to bring together?
The whole Jefferson County, whoever is providing certain services, okay. All the primary service providers and everybody, all the regional hospitals and stuff like that. This specific grant is for health literacy, how we want to achieve better health among all age groups, whoever is Medicare and Medicaid, and whoever is coming to our clinics, as well as who is going to in hospitals and primary healthcare providers in general. So we have been working with top to bottom and bottom top approach. We have programs like Healthy Start, Hands, WIC, and everything. I'm in the advisory role for Healthy Start evaluation, and we are trying to do case management, and we go home visitation, and not me, but people would go, and then we are trying to provide families support in regards to how they can achieve better results being a new parent, or as well as, it starts from you're planning to have a baby. So it's top to bottom approach, and bottom top approach, we are trying to generate health literacy. Like, for example, if somebody goes to a primary care provider, if it is a mother, if she goes to a primary care provider, okay, have you had pregnancy, depending upon your record, the physician is going to say, like, for example, me, I have a 3-year-old son, and another baby is coming on my way. So, okay, these are the services, and these are the programs available out there, and these are the people that are going to provide you some assistance if you need anything. If you have high blood pressure issues, okay, this is how you can manage. And, if it is a older woman, like 50 above, if it is a woman, okay, do you have Medicare, Medicaid? If you're, unemployed, these are the assistance you could, We are trying to distribute literacy pamphlets and, some educational material, as well as they would also ask you about, okay, do you know if you are above 50-year-old, you can get screenings such as mammograms and everything for free. Do you want to do that? And if you want to do that, this is where you go. So we want to kind of generate a system change approach. So there is a lot of literacy, because we found out that that's the major gap. We have been providing all these services from the health department, but only few people know about it, or maybe they don't know about what is closer to them. Maybe they are traveling very far to get the services, and maybe that's the limitation. I can't drive that far, I don't have a car, things of that nature. We are starting to think at a very basic level, so like that. And I'm also evaluating another grant. It's a CT.
Wait, maybe I'll stop you there.
Okay.
Thank you so much. I think for both of you, I'm hoping that at some point, if you haven't already done it, you're thinking about your theories of change, either for the specific components that you've talked about, or for the process of integrating all those services. And for you as well, the different components. It's very important that we not just think about programs in terms of activities. Both of you described activities, and I understand why it's complicated, but the theory of change for the components and for the collective set of activities is very important if you want your evaluation and to succeed, and you want to know why your program is successful. Okay? Thank you. So it sounds like a lot of us are here, and we need special tools in order to make sure that we're designing the proper evaluation for complicated situations. And I'll talk about some of that in a moment. All right. So actually, maybe I'll talk about it now. Who's heard of developmental evaluation? Who's done a developmental evaluation? Developmental evaluation is an evaluation approach that is emerging that is dealing with complicated situations and even complicated plus situations. So what do I mean by that? Here we probably know that we would like to have good child outcomes, maybe good health, good child development. We might even be able to articulate some of our outcomes that we hope to measure at age, whether they're ready for school, when they're navigating adolescence, etc. In developmental evaluation, we don't necessarily always know where specifically we're going. So the idea is that developmental evaluation is an evaluation approach that can assist social innovators develop social change initiatives in complex or uncertain environments. So social innovators, the idea behind that term is that people know that something has to change. They know that whatever we've done before hasn't worked, and we're going to try something different. And we may try multiple different things to achieve a general outcome, but we don't necessarily know where we're going. So the idea of developmental evaluation is that you use evaluation approaches to give rapid feedback about what you're doing. So imagine that you have 5 years of funding for a program, and you, again, want to innovate, you want to implement some new things. You don't know exactly what outcome will be impacted, and you may not necessarily know the pathway and whether the pathway will be straightforward. So you use developmental evaluation in rapid feedback cycles to help you trace your steps along the way. Hopefully at some point things will stabilize, and then you can implement a standard evaluation. So developmental evaluation originators, which essentially is Michael Quinn Patton, I'm thinking that you all have read something by him, liken their approach to the role of research and development in the private sector product development process, because it facilitates real-time or close to real-time feedback to program staff, thus facilitating a continuous development loop. Okay? This isn't just a series of formative evaluations. The idea behind formative evaluation is that formative evaluation, you have your concept of your program, your concept of your outcomes. Formative evaluation makes sure that you're on track, but you're not necessarily going to redesign the program with formative evaluation. I mean, sometimes you can. You can say, this is really not working, and I'm going to throw it out. and you don't go any further. But the purpose of formative evaluation is to do a few mid-course corrections to make it better, to make it more closely adhere to the theory of change. So this is not a series of formative evaluations. Who doesn't understand that point? Okay, so this is a usual program evaluation where you've got your plan, you've got your inputs, you've got your activities, you might do your formative evaluation, and you fix it up, and through this period here, you're gonna do your summative or your outcome evaluation to see if you've achieved your vision. With developmental evaluation, you've got your plan, you kind of have a vision, but then you realize maybe the inputs that I originally thought of aren't the right ones, so I'm going to add some of those. I'm going to add different inputs and try these things out. Some of them are heading in the right direction. Some of them are taking me off on a tangent. I don't know where. So your plan kind of falls apart. And you might, through developmental evaluation, trace several of these pathways, probably not all, to see if you're going in the right direction. So this one, you might not continue. You might say, hey, let's stop that activity. Some of these seem to be going in the right direction, et cetera. Okay, so that's the idea behind developmental evaluation. Now, I'm not saying all of the programs that you raised your hand about that you said were complex, require developmental evaluation. I'm not saying that. I think you probably have more of a vision. You have a set of outcomes. But you may want to draw from some of the lessons learned from developmental evaluation, because maybe your program doesn't fit so neatly into the kind of formative, summative evaluation model that we typically learn about. Okay? So traditional evaluations, we might ask questions like, where have problems encountered in implementing the intervention model solved in a way that is faithful to the model? So this is about fidelity and adherence. To what extent have intervention models specified outcomes as achieved as predicted? So did we actually achieve our outcomes? Did our model predict it? And what has been learned about how to fully and faithfully replicate a model? Again, you're seeing that theme of fidelity to the program theory, not to the elements necessarily, but to the program theory. Okay? Developmental is what intervention model is being developed? What is the theory of change? What are the outcomes that we're hoping to achieve? How is what is being developed and what is emerging to be judged? So, you know, can we do a summative evaluation for this, or is it changing so much? And given what has been developed so far and what has emerged, what is next? So again, that's fairly important in developmental evaluation, is figuring out where you're going next. Not everyone has the luxury of being able to do this kind of evaluation. Funders, I think if you wrote about this, wouldn't necessarily be thrilled with what you're writing about. I think they're looking for the standard outcome evaluation. They're looking for hard impacts. They're not comfortable with uncertainty. I think there's increasing recognition about the use and importance of developmental evaluation strategies, but I'm not sure that they're there yet. Here's some other ideas about what developmental evaluation monitors and assesses. It can look at the changes in the relationships between the components of a system. So I heard about integration. Maybe we would see what components of the system is being impacted or not. I'm working on sort of an integration as well in Toronto. You know, there's these big plans to integrate primary care into all kinds of other social services. And what we're finding is that there's a lot of primary care providers who are totally outside of the group that is actually being integrated, especially private docs who are solo practice. They just aren't really integrated in the system, and a lot of their patients are the ones who are not being referred to the right services. The appropriateness and the boundaries of the use for the components of the system. So again, I was just describing to you, there's a group who's in, there's some group of primary care providers who are in, those who are linked to hospitals, those who are linked to community health centers, and then there's a group who's out. So we have to decide, do we want to bring those groups that are out in? and then the different perspectives about what changes and how it changes through the development, through a development intervention. So looking at the program from different perspectives, not just the participants and not just the designers, but others even from the outside. So these are the kinds of things that you might look at. I want to describe a little bit of an example of a developmental evaluation that happened informally and perhaps by accident in the Healthy Start evaluation that I was involved in a long time ago with the first 15 Healthy Starts. So we began with a program model, and these are the activities. They're not the theory of change. Shame on me. Okay. So we intended to serve women in the community. So there was a set of, there was a community that had a geographic boundary. And the idea was to reach 70% or more of the women to ensure that we're getting at the high risk. If we just open the doors of Healthy Start and let anyone come in who wanted to, we might be getting those who were doing really well. They're motivated to come get services. So we did intensive outreach to get 70% or more of women in that catchment area who were pregnant or new moms. And then the idea was to get women into prenatal care early. Okay? So that's how the program was first conceptualized. Then it moved on to the same things to get women into prenatal care early, but with time we learned that women, even if they were pregnant, wouldn't even think about prenatal care or health care or anything like that until they had their urgent needs met. We called them emergency needs or urgent needs. So some of them were having their electricity shut off. Some of them couldn't feed their kids or didn't have diapers. Some of them couldn't pay their rent. Some of them didn't have windows on their house. So things like that were urgent needs. So the program took to first engaging women by saying, what are your urgent needs? That's the first thing that was said to them, not, oh, you're having a baby, get into prenatal care. So urgent needs first. Once urgent needs were addressed, then it was, we're a program about infant mortality prevention, et cetera. So then there was this goal to, all low-income women, try and help women become more economically independent. How do we do that? We noticed that there was a high high school dropout rate, and so the women in the program weren't prepared to be able to get a job because they didn't have high school graduation. And they didn't have some basic skills. And so we thought, okay, well, we'll put a GED program into the center. So there was a center there. So there was a GED program offered to everybody, anybody, and with childcare and all of that. Made it very easy for women to come and do their GED program. In doing that, we discovered that, in fact, women didn't have the literacy skills to even do the GED exam. So then it became a program of getting literacy skills up. So it was a 2-year literacy improvement program, then the GED program. But you can see that the program is evolving based on its learning. So, oh yeah, absolutely.
Now, what would you put as a theory of change? It looks like you're still going.
No, this is just a summary of what I just said.
Okay, so I guess what would you put as a theory of change?
I think the theory of change, that's a really good question. So let me just put up a figure that I have here. I think our theory of change is about, so you're familiar with Dahlgren and Whitehead's social determinants of health model. I think the program designers were very much about, let's see, living and working conditions, unemployment. They were here. So the people who designed the Healthy Start in Baltimore were people who were in the war on poverty, you know, in the 70s. And so for them, they viewed all of these problems as a consequence of poverty, which I think is probably true. So I even heard them at one time say, you know, we can pretty much make our program work for any health outcome because the root of the problem is poverty. So when they dealt with their urgent needs, for example, what they were dealing with was they were addressing the fact that these women didn't have money to buy food or to pay their rent or to fix their house that the slumlord wouldn't fix. So that was all about poverty issues. Also, women didn't have the skills to be able to get employment, and in part because their schooling wasn't appropriate in the neighborhoods that they were in. I'm not sure how much you know about Baltimore schools, but they're not very good, et cetera. So I think their theory of change was really about the social determinants of health and addressing the social determinants of health, bringing in programs to help them do that. So the other thing that I didn't put on the slide is that Healthy Start wanted the money to stay in the community, and so they ended up hiring people from the community. They gave them experience, training, skills, so that the money that was being given to the program Healthy Start was staying in the community, because these communities were extremely poor. Unemployment rates were well over 50%, sometimes 70%, men and women. So they hired men and women. So they had like housing programs, and they hired the men to help with the housing programs, like remove lead, things like that, men from the community. So I think their theory of change was we need to address the issues that the social determinants of health that are contributing to poor preconceptional health, which again are all related to poverty. And in order to improve health, we need to address these issues. Does that answer your question? Yes. Yeah. Okay, so back then to okay, so this is how the program evolved. And I think I'd have to say this was before developmental evaluation, but in some ways this was very much a developmental evaluation example, because the program did have plans. They definitely started out actually trying to be like other programs. Maybe I'll go back to this. The program started out really trying to work here. So they had parenting education programs. They had programs that were, they had a kitchen built in the center, and they had programs to help you learn how to cook, et cetera. But they realized that those weren't really doing anything. It was the urgent needs program and the housing improvement programs and employing them and getting them to have work experience so that they could move on. Those were the things that were actually having more of an impact. And so in some ways, while they didn't call it developmental evaluation was helpful. And I think if it were more formal, so what would happen is they would run up against a wall, the program designers. They're like, oh, the outcomes that we thought were supposed to happen weren't happening. And then they would step back and think about it, and then they would change directions. So developmental evaluation, that process did help, even though it wasn't called developmental evaluation at that time. And I think if it were more formalized, it could have been more efficient, right? 5 years isn't that much time to be able to keep redesigning your program and then having an impact, okay? Okay, so what questions do you have about developmental evaluation, or stories to share, or thoughts? Yes?
Was it 5 years that it took to go through that whole process? How many people were? How long was that kind of iterative process of designing and redesigning, and then how many people were involved with that?
So yes, 5 years was the length of the first grant. Actually, I think it might have been 1 year of planning and then 5 years of program. And I would say they would reevaluate probably almost once a year, and then they would iterate. And again, it was a very bottoms up. So they would, it was a good system in that they would listen to the case managers, and the case managers would say, this is my barrier, that's my barrier, this is my barrier. I was the evaluator, so I would try and look to the literature. By the way, the literature didn't help at all. This is why I wrote that book, because we need either better literature or better ways of sharing our stories about things like this with others, so that we're not reinventing the wheel all the time. But yes, it was 5 years. Of course, Healthy Start has continued since that time, and the Baltimore Healthy Start has continued, and I'm sure they've gone through many more iterations. But yes, a lot of this happened during the first 5 years. Yeah.
How do you distinguish the key drivers of change while it's happening? How do you know what are the components that are really working?
For a theory of change, like a critical ingredient kind of a thing? Is that what you're asking me? I think that's a great question. If you can hold off on the answer to that question, when we talk about logic models, I kind of want to go into that because my observation has been, and again, I think evaluation has improved since I've started. That's the good news. A lot of programs don't know what their theory of change is. And that's okay. They actually know in here, maybe their gut, what the theory of change is, but they haven't articulated it and written it down. But we're going to go into that, if that's okay with you. Yeah?
This is related. I mean, how did they know? You said that they could see that the self-efficacy training things weren't working and the social determined things were. So how could they know?
As I mentioned, their background was really about the war on poverty. The programs that they had been designing were really about addressing poverty. I think the way in which they designed their program to begin with, so they didn't just go to a hospital and open the doors or the health department and open the doors. They went into the community and built a building that was really an attractive new building that had built-in childcare, washing machines, all these things. They knew that, they sort of knew intuitively from the beginning that poverty was really at the core of the problem. So I think that was their lens from the beginning. Although I did tell you in the beginning it was about prenatal care. So in the very beginning, so the honest truth is they brought in a consultant in the very beginning. They were poverty people, but they brought in a perinatal expert consultant, very well published. And that's what they were told. You're not getting women into prenatal care early enough. So then they said, okay, we're going to do that. They bought a van and they, went around and tried to get women into, come on, get into the van. We're going to give you a ride to the, that's what they tried to do, follow the advice of that expert. But that didn't work. So then they started, again, following their gut, listening to the, okay. A couple more things. I'd like to talk about systematic reviews. So who here has not heard about systematic reviews? Who's done a systematic review? Okay. Systematic reviews are really an important tool. Systematic reviews are great because they don't pick and choose evidence. They take all of the evidence on a topic, all of it, good, bad, negative. And then you synthesize the information, and then you come up with an answer about whether program A is effective or not. Systematic reviews, so they're in theory unbiased in that way. You're not just picking only the successful programs, but you're also learning from the failures. The challenge with systematic reviews is they're wonderful for simple problems. When you talk about evidence-based public health practice, all of that, that's located in that box that I showed you in the beginning, the simple box. Okay? When you've got complicated or complex in particular, you ain't going to find a systematic review for those because they're context specific, they're population specific, things are iterative, okay? So I say that, but then I'm also going to tell you a story about how we can do systematic reviews for complex situations. Has anyone, okay, well, we'll get to the next topic then. So anyway, use systematic reviews when you can. There's great databases for the results of systematic reviews. There's the CDC, US Preventive Task Force. You can just look up what the issues are, and they'll tell you if there's a systematic review. There's NICE in the UK. So there's lots of databases that tell you about systematic reviews. There's emerging databases that tell you about social programs as well, and the results of systematic reviews there. Of course, there's Cochrane, and there's even, I think Cochrane is doing social as well. But anyway, use them. They're an important source of evidence. You're not just relying on one study or another. So who here has not heard of realist evaluation? Okay. So realist evaluation is a type of theory-driven evaluation method used in evaluating social or health programs. And it's based on the philosophy of science called critical realism. And to contrast that with positivism. So if you're trained like me as a social epidemiologist, we are trained to, as positivists, what that means is we're trained that whatever we measure is the absolute truth, okay? Critical realists say there is a truth and we can measure it, but we can't measure it exactly, Okay? There's imperfection in how we can measure it. We try to improve our methods to get closer and closer, but we're never going to get at the truth. So again, in epidemiology, I'm oversimplifying obviously, but in epidemiology, if we measure a prevalence, that's the absolute truth. If you were a realist, you'd say, I measured a prevalence using quantitative methods, but that's probably not exactly right because I can't actually get at that with my tools, okay? So theory-driven, and so the reason why realism uses theory is because we use theory to explain the world, okay? Based on specific theories, realist evaluation provides an alternative lens to empiricist evaluation techniques for the study and understanding of programs and policies. It acknowledges that research and knowledge is a social and historical product, it's imperfect, and that the social and political context as well as theoretical mechanisms need consideration when you're doing realist work. Okay? You can use all the same methods in realism, qualitative, quantitative surveys, all of that, even randomized trials, but we just approach it differently in terms of how we think about it, and there's always theory at the center of it. We start with a theory, we collect our data, and we confirm whether that theory was true or not, and then we end with the theory. So I'm going to tell you about, some of you may not have heard of it in part because it's something that is emerging. So if we look at the number of peer-reviewed publications with realist in the title, you can see that in 2005 it was close to 1. It was very low. And then it's increasing, and now it's really taking off. So the popularity of this is because it deals more explicitly with theory, and we're testing theories in evaluation, not so much. It doesn't mean that you can't also measure outcomes. You do, and that contributes to your understanding of whether that theory is working, but we're not ignoring theory anymore. And I think that's one of the key advantages of realist approaches is that we're not ignoring theory, and theory is front and center. So I'll tell you the example that we did a realist systematic review. What is that? That is a systematic review of essentially program theory. We did a realist systematic review of partner violence screening in healthcare settings. So since, I'm not sure how familiar you are with the issue of partner violence, but partner violence is a major public health problem. And since the 1990s, there have been lots of calls for universal screening in healthcare settings, but to date, there's very few effective programs that are in existence in healthcare settings. And also there were, we did this review starting in 2009-ish, and at that time there were several systematic reviews, quantitative traditional systematic reviews, all concluding that there's not enough evidence to support the idea of partner violence screening in healthcare settings. And so I think that let healthcare settings off the hook, so they weren't doing universal screening. And from my perspective, there were lots of flaws with those systematic reviews. I mean, I think there were 6 to 8 or some of them. So I decided I was going to take all that evidence and reevaluate it from a realist lens. Long story short, we identified, we started with the theory. It was a pretty crude theory. And this is our final theory. I'll briefly explain it to you. You can read the article. It's published in Social Science and Medicine. But we definitely, our initial theory was something like, we thought it was important to have supports there for the person who's doing screening. If supports meant maybe a valid tool, or supports meant they had training so they understood violence, because there was a lot of literature suggesting that healthcare providers didn't actually understand violence. You know, they had these ideas that, well, if a woman wants to leave, she will. We don't need to screen, those kinds of things. And when we reviewed the evidence, again, that had been included in all the previous reviews, we came up with a different conclusion. We came up with the conclusion that there is evidence to support routine or universal screening, but that the theory is that all of these activities, so staff training, a protocol and valid tools, and in particular, immediate and easy referral of the person who says, yes, I'm experiencing abuse, to either on-site or off-site services of wide variety, other health, housing, employment, justice, legal, et cetera, had to be in place, and that they all work together to increase the screening confidence or the self-efficacy of the person doing the screening. If these things were not in place, or if only one was, let's say, because a lot of times screening programs will say, here's a tool, now everybody administer this. That alone is not enough. A key driver of success is high institutional support, oftentimes because they'll make the connections to outside community linkages, but they may also provide training and sort of a culture of support for the idea of partner violence. So this is an example of a realist systematic review, which is based on theory. It did come up with different evidence and conclusions than some of the non-realist, non-theory-based systematic reviews. So I wanted to make you aware of these approaches because they are emerging, and we're finding them useful. Another example of a realist approach is this article looking at the benefits of CBPR, community-based participatory research. I'm hoping that all of you have heard those terms. This tells you the critical ingredients that make CBPR successful. CBPR has been around for a long time, and there's a lot of people who say, well, what's the value added? It just takes a long time. It doesn't come up with any benefits. Well, this will tell you what the benefits are. Yes, you had a question in the front?
Can you go back to the slide?
Yeah, sure.
Do I need the microphone?
So this looks, what's interesting about this, and I was wondering this even back when you're talking in terms of developmental evaluation, and then as you move forward into the realist systematic review, to me this feels like a more robust version of what we use in quality improvement programs and when we look at the key drivers, and usually that's a more simplistic design. Mm-hmm. And I think that the difference here is you've got arrows going in many different directions. Is it kind of is it similar to the theory behind quality improvement programs and key drivers, but a kind of a more complex way to look at it?
I think that's a great question. I think there is this, so there's a broader question about, is QI evaluation? Right? There is that question, and I think we're going to try and talk about that. But then these arrows are arrows that are based on the evidence that we synthesized. So this particular picture is not an ideal version of what should happen, but it's based on the evidence that we found that supported these arrows. So I don't know if in QI that happens, but this here is based on the evidence that we've found, if that helps you understand it. It's not an ideal picture of how screening should happen. It's the successful programs worked this way. By the way, we learned a lot more from failures than we did from successes, because there were few successes, many, many failures, and we learned a whole lot from the failures. That's the other advantage of realist review, is there's a theory in many of the programs that just say, here's a tool, everyone's going to use it now. It says that all you need is just that screening tool, and that's all you need, and everyone's going to administer it. Well, that doesn't work at all. That doesn't do anything about the high level of screening confidence. We learned a whole lot about high level of screening confidence. For example, there are estimates that suggest that 1 in 4 women will experience violence in their lives. A lot of the screening confidence had to do with women staff dealing with their own issues of violence. They had never had to or had the opportunity to deal with their own issues of violence, so they weren't feeling comfortable asking anybody about theirs because they wouldn't know what to do if a woman said yes. So we learned a whole lot more about that, but that didn't come together kind of here. That's discussed in the paper. Anyway, but that issue about QI versus this, are they one and the same? Are they similar? I would think we can use similar methods to address QI issues versus evaluation if in fact they are distinct, but we're going to be talking about that, I think, tomorrow. Kristen, did you want to say anything about, before we get to the, I'm going to give a little background and then we're going to get to the exercises. Do you want to say it then? Okay.
Just the format of today, we're going to be doing a lot of moving back and forth because we want you to be working in teams, then getting feedback from Dr. Ocampo, and then working in teams again. So we have like a pretty tight schedule for that, so if we can just move quickly. But you can look in the group assignment area, and there are assignments for your evaluation group. It'll be a different team than you worked with for the exercise on Monday. 5 of the groups will be in the other room. We're in Plaza B right now. 5 of the groups will meet in Plaza A to kind of just spread you out a little bit, and 5 of you will meet here. So just when Dr. Ocampo's done with her section, kind of setting you up for the exercise, I think there's going to be a break at 10 o'clock. But like maybe just kind of do your break as you're kind of convening in groups, you know, to kind of keep things moving along. And then keep an eye on the time, and we'll be shuttling you back and forth too, because we want you to work a little bit and then get some feedback and then work a little bit more. Okay?
Great, thanks. Okay, so I have about a half an hour to get through these materials. Let me see if I can do it. And this is designed to be background for your first and second assignment. So everybody is familiar with this cycle, right? It was part of your background readings. It was the CDC publication on evaluation. This is the evaluation cycle that they talk about. I think the picture is prettier in that document. But we start with engage stakeholders and then describe the program and then focus the evaluation design. So I want to talk about those things right now. Maybe we can do a very quick exercise to kind of get you warmed up, if you don't mind. So in thinking about stakeholders, all programs are going to have stakeholders, right? So I wonder if black is better. Can you give me 4 or 5 stakeholders for this program here? This training program. Yes?
Local health departments.
Local health department. Okay, and why?
Just to support, build the infrastructure or resources.
Okay, they want to have their infrastructure built and their capacity built. Any other reason?
They're the end users.
Of your training, the end users, okay, yep. In order to build capacity and institutional capacity, yeah. Any other reason why they care about this?
Health of their population.
Health of their population. Okay, so they improve the health of the population. Okay, okay, who's another stakeholder? MCHB, is that what I heard? Yeah, okay. MCHB, why? They, okay, so they're investing money, they're the investors. Okay, what else?
How they can support national goals.
They want to support national goals, good, okay. Okay, who's another stakeholder? Yes? Okay, the trainees. Why?
We want to learn new skills.
Okay, you want to increase your skills. Anything else? You want to be out of your office, sure.
Share ideas, good and bad.
Share ideas, okay, network, good. What else?
We want to stay employed.
Stay employed, and then, sorry?
We want to improve our programs.
Improve your programs and stay employed, okay. Improve programs, skills, and then employability. How about that? One more. Who's another stakeholder? State Title V? Why?
Well, I mean, I'd almost put them like with local health departments as well.
Okay.
Instead of probably the city.
Okay. That's all right. They're in the same group. Okay. Who else then? Anyone else? No more?
The participants of our programs, the actual community members that we're measuring.
Okay. Program participants. Local program participants. Is that right? And why is that?
Because ultimately they're going to be the ones that benefit from improved programs.
Okay. Okay, from improved programs. Whoops. Too close to that thing. All right. So this next piece is a little harder. All right, let's pick two. Who are the two most important stakeholders? Okay, I'll just do a show of hands, and we'll do it by count. Who thinks it's the local program participants? Raise your hand. You get one vote. All right. Who thinks it's the trainees? You got to raise your hand high. Okay, good. That's above this. Who thinks it's the Bureau? Okay, and who thinks it's the local health departments? All right, I think it's local health departments and the trainees. That doesn't mean that that's right or wrong, but let's work on those. So I want to ask you now, if we were doing some process evaluation, okay? What would be one question that you would ask that the local health department will want to know? Just the question itself, not how you would measure it.
Did you change your practice because of this program? Do you have a skill that will benefit us because of this program?
Is that an outcome or is that process? I think that's a great question. So the answer was, did you change your practice or your behaviors or your approach to things because you attended? So my question was, is that process or is that outcome? Outcome. Okay, what's a process? It's a good thing to measure, but what about process?
How many people did you train?
The local health department wants to know how many people they sent. Okay, how many people did you train? Okay, I think that's process. Yes?
Did they really improve the skill set because of the training?
Okay, that might be outcome. Yeah? Yes?
Did our participant actually attend everything?
Yeah, that's right. Were they out partying at night and going to the museums during the day, or did they attend? Good. Okay, what about trainees? What do you care about, process-wise? Yes, in the back. Okay, were the training materials accessible? Is that what you said? Okay, another one? That's good.
What material was covered?
What material was covered? Okay, good. So was it something you already knew, or is it something that you could really improve upon? Okay, so this is like your warm-up, right? You have your 5-minute warm-up when you exercise. We're just sort of getting ourselves into this, because we're going to have to think quickly on our feet when we're doing this today. Okay. So stakeholders are very important because we're doing the evaluations for them. We're not doing it because we're having fun. We're doing it for them. It has to make a difference for them. So we have to make sure that our questions match what their interests are. Ideally, the primary audience or the primary stakeholders. So we have to think about all that, and we have to connect the dots. Logic models. One of our exercises is about logic models. So who here has not done a logic model before? Great. Oh, there you go. Okay, but you'll have team members who will help you. So logic models are important because they allow you to look at all of your program, the synthesis of your program, to successfully convey what's important about your program. Ideally, it will reflect your theory of change. And it's a tool that should be kept up to date, okay? So the idea behind a logic model is that you talk about your resources or your inputs. What are you putting into your program? The activities, the outputs, right? So we talked about whether skills have changed, et cetera. The activities or the 1-week training, the faculty, the choice of faculty, et cetera, if we're talking about this program here. Outputs, outcomes, and then your ultimate impact. The idea is that there are resources that are needed to go into the program. Again, we need a place to train. It needs to be centrally located, appropriately resourced. We need to have faculty. We need to have this training and exercises and activities, breaks, things like that. Then if you have the right resources and then you have the right activities, then you will hopefully have some kind of an impact, right? You'll have people who are trained, people who are knowledgeable, they have new knowledge, et cetera. They can take it back to their workplaces. You'll have better programs. You'll have an impact on local health department and state Title V, and then improve population health. So this is the idea of your logic model. It's the basic skeleton. They come in all forms. So here's one here about a parenting program. So the inputs that they have are staff, money, and then their community partners. They actually designed a parent education curriculum, and the idea is they're providing 6 interactive trainings for the parents, and they want to target certain kinds of parents to attend. And then you have their short, medium, and long-term outcomes. I won't read them to you because you can read them yourself. This, by the way, is not reflecting a theory of change. You can put your theory of change in logic models, or you can have a different theory of change logic model, but you should ideally know more about what is it about that curriculum that is going to make parents change, right? So it's important to know what the critical ingredients are. So I mentioned earlier that, and again, this isn't a theory of change logic model, but there's a lot of programs that don't necessarily know what their theory of change is. They might know what their activities are, but they don't know what their theory of change is. So I'm sorry, I forgot your question. Your question earlier in the front here was, yeah.
Was it the QI question?
Yeah. Oh, thanks.
I'm sorry.
My question was around looking at what you presented today. A lot of what you're talking about sounds very similar to me as to what we do in quality improvement projects, and the logic behind the key driver diagrams that we use, and rapid cycle feedback, and continually updating how we look at things. Okay. So to me, it resonates in terms of how we look at quality improvement projects, and I was wondering if it was really similar.
Okay, so it's slightly different from what I'm going to say. So I think I may have answered your question last time. So when I talk about logic models and theories of change, I mentioned that there are many, I've encountered when I've done evaluations, program designers who don't necessarily know what their theory of change is. Maybe they've borrowed their program from an adjacent county and they've had success with program X, so I'm going to do that too. They pay attention to the program activities. They know that they need a case manager, or they need this, or they need peers, and that's how they focus on the program. But I think I told you that I think people know what the theory of change is. They just don't articulate it and put it on a paper like this. So one of the activities that we have done when we've gotten programs to try and articulate the theory of change is you visit either the front lines, you visit as many people as you can who are involved in the program, hopefully with some experience, frontline workers, the program designers, maybe even the investors, maybe even the original program. So if the program is borrowed from someplace else, maybe you can talk to them, and you essentially just start asking them, so when you administer this program, what changes do you see in your parents? And they'll say, you know, the parents are more nurturing. Well, why is that? So when you ask why, and oftentimes you'll have a sticky, you can put it on a Post-it. So parents are more nurturing. Why is that? And then you can begin to construct the theory of change from what they tell you about why. They're observing it, or they're delivering the program, or they know what kind of questions they get from the parents, so they may know what's changing. Anyway, you can kind of elicit the theory of change if you don't have a formal theory of change about your program. Again, you can also look at the original program if it's borrowed to see if there's a theory of change there. But there are ways to get at the theory of change that I think is often unspoken or unwritten, and it's being implemented anyway. It's being acted upon in the program. Logic models can also be linked to your assumptions and external factors, and then your evaluation questions. So you have your evaluation questions about process and about outcomes, and then you can also have your indicators here. So you can expand upon your logic models to include more than just a picture of what the program is about. You can, so for example, here we have your inputs, outputs. It's just like it was before. Our evaluation questions might be, were the inputs sufficient and timely? Or was the curriculum developed and were all 6 sessions delivered? And then you have your indicators down here. So that you can link very closely what your questions are and your indicators are to what your logic model is. Now, in all likelihood, you're not going to answer every single one of these questions. But again, you talk it over with your stakeholders and you figure out what they're interested in. Your investors are going to be, did we actually put enough money into this, right? But the trainees and health departments are going to want to know more, okay, so what kind of an impact and what kind of change can I expect? That way you can prioritize your evaluation design. You can mix and match the questions, and then mix and match data sources to come up with a design that fits your program, right? We're getting into the focusing the program piece of it now. And so here, I've just linked the stakeholders. Which stakeholders are interested in these data? So you can just keep going with your logic model and laying it all out there and then mix and match and pick and choose. I'm going to give you an example of a logic model which is looking at a ready for school and successful at 3rd grade program. So the ultimate outcome for this program here is success at 3rd grade, right here. Children are successful at the 3rd grade, and that's what they're working toward. But they're working with younger children, okay, with preschool children, making sure they're ready for school. And this particular logic model is showing you what activities are going to lead to outcomes, different outcomes, and then ultimately to the success at 3rd grade. So you want to have healthy and well-timed births that are not premature. So you're going to have a lot of activities around pregnancy and making sure that there's good health of the mom who's pregnant. Then you want to track development. So you want to track the child in the early years. You want to support families. Anyway, you get the idea, of how this works. So this is a way of working backwards from your ultimate outcome to the outcomes for some of your activities. Are there any questions about this? Again, logic models don't have a fixed format. They have different kinds of formats. But this is a way for you to trace the activities to specific outcomes or areas for this particular program. I think later we're actually going to go over, you have this in your books. This is the logic model for the Transformed Healthy Start program. So this is definitely not simple or complicated, it's complex. And it's multi-level, right? So we have multiple levels of influence going on here. So we're probably going to go over this a little later. I do want to talk about process evaluation because that's your second exercise. So, sorry, before I go on, what about logic models? What questions do you have about logic models? Yes?
So in the logic models, how do you build in those, in research terms, or we would say confounding factors, or those external things that are going on that are probably other programs layered on, or where do you put that in the logic model?
So you could do it in your assumptions, right here, or your external factors. There's 4 competing programs that are working on the same thing. We want to attribute success to our program. That's going to be really difficult, but you can put it there, or assumptions. We're working in the context of other programs, so we won't be able to attribute success just to our program. Did I see another hand? Yes.
You know, this is something that I really, because I came to program evaluation after epidemiology. So, you know, I always see in the long-term box that the goal is to lower rates of disease X, disease Y. And it's something that really drives me nuts. I don't know if it's anything that drives anybody else nuts. But, you know, to me, it's like you're almost setting yourself up to never be able to measure your long-term impact.
Because you don't think the model works, or you think you're always working here and then you're revising and working here?
No, even if I see a drop in population rates, I can never attribute that to my program specifically. So is there another way to get at long-term outcomes and impact that would be an improved way to measure specifically for my program? And if it's not, if there's not, it's okay. If that's just what you put in the box, fine, but it's something that drives me nuts, and I don't.
So I think one thing is to disclose, you know, maybe your assumptions. I may never be able to attribute drops. I mean, that's what happened with the original Healthy Start, right? Infant mortality rates were dropping. Was it because of Healthy Start? Well, they were going down everywhere. I understand what you're saying. I think the idea of attributing success to a particular program, especially when you're working with population outcomes and not people who come to your center or your program, is a real big challenge. Because you not only have other programs who are working on that, you could have forces that are counteracting what you're doing as well, right? So, you know, you could be working on pregnancy issues, but then there's a whole housing foreclosure thing that is happening, and, you know, so it's good to be able to articulate some of those things. I think we probably still go through the exercise of having short, medium, and long-term goals, but I totally understand your question and issue, and it's a big one in the evaluation field. How do we actually attribute success to our program? It's tough. Has anyone been able to do that and have a good answer? Yes, your question?
I had a separate question. It was mostly on indicators. We have a hard time coming up with indicators that. So my question's on indicators. How to, you know, come up with the indicators that align with the inputs.
So what's an example?
Like in our program, it's Adolescent Family Life Program, and we're trying to launch a new intervention called Positive Youth Development. So under inputs, we'll have high expectations or caring adults, and then the youth who's able to set goals and accomplish goals, and then, you know, we're trying to figure out certain resiliency measures that pertain to these attributes or inputs, and, you know, through literature review, and there's lots of literature on resiliency measures, but we just have a hard time.
Yeah, I mean, I have to admit a lot of my ideas for evaluation don't come from the literature. And sometimes you have to be creative on your own and come up with some things that you're doing in your program. So if you're is it curriculum based, or what are you actually doing?
Yes, well, we're developing the curriculum.
Oh, okay,
yes.
So depending on what you're doing, you may want to say, if I do X, I should expect you know, at least half the adolescents in my program to actually be able to articulate goals. I'm going to give them a tool. I'm going to give them a little framework where they can actually articulate their goals, or work in a group and articulate their goals, so that half the adolescents will come with something complete that they feel they can own. I'm just making this up, but you can do things like that. Yeah.
Thanks.
Yes, in the right behind. And then
I just wanted to maybe throw something out for her question about how you can attribute your success to the specific program. Maybe we can try to maybe do some research on what is out there, how many people did what kind of programs as a part of Healthy Start to achieve some certain goals, and try to identify a gap that exists within your community that everybody else had done or hadn't done, and you want to try it on because it is more relevant to your population. Try to identify a certain thing, and then maybe come up with a case control kind of a design within your population of for the program, and then measure like do a pre-intervention and post-intervention kind of case control study. And then you can evaluate maybe if there is a change, typically when along with all the intervention activities and this one special characteristic that you have included, if that had made any difference. So that might be a little helpful for you to attribute. Okay, thanks.
And I think that's a great idea. I mean, we'll go in later to the idea about designing your intervention, but maybe you can, if that's really important to you, you can design your intervention in a way that you'll be able to test. So here, here, and there. So go ahead.
If you have control over actually doing a case study, I love that suggestion. Unfortunately, in the world that I work in, usually we don't have case studies. It's just we have all these programs going on out there, and so one of the things that we're doing, and I mentioned this kind of design, this propensity score matching process, and one of the programs that we have implemented is that we're working with the federal government to implement a program that basically we integrate care for people that are on Medicaid and Medicare. We want to evaluate it, and there's several other states that are doing this very experimental program. And so the federal government, they've contracted this work out to a research team, and they're using a propensity score matching design, and so they recognize that there's a lot of things going on out there in the world, and so what you do is you find people in the population that basically that match up exactly with your study group based on a series of variables that you pick, and so you do some kind of propensity score matching, and then over time you look at the differences in certain outcomes, something like readmissions or ED visits. So you look at the difference, but you actually look at the difference in differences across the populations. And that's a way to kind of get at, well, all these people match up in many different ways, like geography, where they live in metropolitan areas, as well as disease characteristics, and they've been exposed to the same programs. It's like the only thing that's really different is that the study group population has been in the program, and so you do a difference in difference design during this propensity score matching.
So we're going to have a session on propensity score matching. That's the good news. I mean, you're also limited in what variables you have to match, right? And often they're really crude variables, and but again, we're going to be going into that. So I am going to apologize to those who had their hands up, because we need to get through some of this material in order to do our exercise. Let me just quickly go through process evaluation. I suspect it will be fairly straightforward because many of you are experienced. Because your second exercise is really designing a process evaluation. Process evaluation is used to monitor program implementation, and it can aid in understanding the relationship between the program elements and then the program outcomes, making sure we're achieving what it is that we need to. And so anyway, this box shows you some of the things that you would consider when you're thinking about process evaluation and the steps. When we think about process evaluation, we think about several domains. One is fidelity, and I mentioned to you your theory of change, or the critical ingredients that makes your program work. To what extent is your program actually adhering to that? So an example of that is, Olds does all these home visiting programs, and for him, it's vitally important that your home visitors have a particular kind of training. So if they don't have that kind of training, for him, you're not adhering to his model of home visiting. There's lots of models of home visiting, but for his, it's a particular training that they have to have. So we might be measuring fidelity in terms of staff capabilities and skills, and whether they have the training that he says you need to have. The dose delivered, somebody mentioned here, are you actually coming to the sessions? Dose received, so were you here but maybe not paying attention? You were checking your emails or doing something else, so that although you were sitting through the sessions, you weren't really absorbing it. Reach, to what extent did You have, did you reach the population that you were trying to get to, your target population? How did you recruit people? Did you recruit people who were destined to be successful only? I mentioned to you in the Healthy Start program, we had a catchment area, which made it easy for our evaluation, because then we could look to see we were targeting a group, but we also wanted to make sure we got almost everyone in the group. So we were trying to also get at those who are high risk, who might not typically come into a program like that, and context. So these are some things that you might want to think about when you're thinking about process evaluation. I was going to go over some theories of change with you. Maybe I'll do it quickly because this is in your book and you can look at it on your own. So one of the exercises is really looking at a housing program. And let's see. The housing program is designed to enable the participants of Healthy Start to have stable housing. Now the idea, let's see, yeah, it's the same thing. So the idea of this program, of the housing, of providing housing, and it's called Housing First. That is, you give people housing even if they're not necessarily ready to receive housing. That is, they don't have a stable job or they're not necessarily employable today or tomorrow. You give them housing so that they can stabilize their life. This is kind of a theory of change of Housing First. If you stabilize, if you give people housing, here it is. So they also have choice of housing. That's really important. You don't just say, I've got an apartment available, it's right there, and that's what you're going to have. You give people a wide choice of housing. They have you know, dreams and visions of what they want their housing to look like. Not just 2-bedroom, 3-bedroom, but where in the city, et cetera. So you give them a choice of housing. And the immediate outcomes that are going to happen is that you get access also to benefits through case management. You have increased hope for change. You might access some of the interests that are services and interests that are specific to the client. And then, you know, you have greater participation in the management of your own health. Anyway, this is sort of the theory of change and how things are going to happen. Ultimately, you decrease the risk of homelessness, decrease the use of emergency response, like decreased ER use, improved quality of life, and physical health. Oftentimes with evaluations, you just say, okay, I did housing first and I got improved health, and you kind of ignore these pieces here. But in a process evaluation, it would be important to see if some of these things are happening, looking for some of these changes, immediate changes, for example, or whether they got choice. The other exercise has to do with a partnering process, or sorry, yeah, the other scenario is partnering. So developing a community action network. And the Community Action Network is designed to engage a number of different community organizations and key players, cross sectors, not just health, to improve population health, improve the well-being of the population. I've just listed here, and again, this is in your book, some values and some that are important to think about. For partners to be able to work together. These are agreed on principles that really facilitate good partnerships. So one of them is equity, because it leads to respect for everybody in the network, transparency and decision making and thinking about spending money, and then mutual benefit. So it can't just be sitting around my table because you're going to help me with my issues, but there has to be a benefit to everybody who's sitting around the table. And the other thing that I wanted to point out to you is partnerships go through phases and stages, starting with scoping and building. So who should be in the Community Action Network? And the activities when you're building are going to be different than when you're actually managing and maintaining and implementing the activities of the Community Action Network. So I just wanted to identify the principles that are important for successful networks, and then also identify that the activities are different depending on what stage you're at. And in your description, it talks about what has happened so far. So it's beyond just scoping and building, but it's probably somewhere around here. So I'm going to stop there and see if you have any questions about your assignment. So have you looked at your assignments? So in the exercise section, you should see for evaluation, logic models, etc., your name in one of the groups. Did everybody find that? So there's two columns of folks, right? So one column gets the housing, and the other column gets the can. Okay, everybody with me there? And then are the exercises in that section? Sorry, my book's in the back. Or the exercises are there too?
The exercises are right after your slides.
Oh, okay, so right after the slides, back in the evaluation section for Wednesday, are the exercises. So who is in housing? There you go. So there's a housing, healthy start in housing description. That will be your set of exercises. And then who's in the can? The others. Yep. Who does not know where they are? Okay. Do you know why? Okay, all right. So as Kristen mentioned, your first exercise is going to be the logic model. I should have brought my book. And you have, I guess there's a break, and then you have until 10:35.
So can I?
Yeah, please.
So that break, you guys can break, but the sooner you get into groups, the more time you'll have to work. So kind of a break and group type thing.
A working break.
Right, a working break, right. And you'll have then until between now, you'll have the break and then your activity through 10:35, and then everybody back in here with questions for Pat to answer that have come up so far, and then you'll get 15 more minutes to work after your questions have been answered, okay?
Now you don't have to, if your group is working fine and you have no questions, you don't have to come back and ask me any questions. I'm just going to be here for you if you do have questions that have come up for your logic model. So you're going to design a logic model, and then we're going to randomly select a couple of the groups to present. So you can write on your sheets. There's a little camera here, so you don't have to worry about the computer or PowerPoint. We'll just display it here, and you can talk about it. You'll have 5 minutes to present.
And if you have any questions,